Hello, my name is David Romaka. The date is November 20th, 2019. Went backwards. This is Case Connection Unit 2. For my case connection, I chose Case 3 and Case 4. Case 3, we'll start there. Case 3 reads, a 5-year-old boy is brought to the pediatrician's office for an annual visit. The mother reports he has been a sickly infant and often appears drowsy. She also has concern over her son's persistent thirst and frequent urination. Blood samples are taken for an insulin measurement at the time of 0 and 1 hour after the glucose loading test. These results of this testing are illustrated in the table below. Serum insulin, patient 0.8, control 0.6 plus or minus 2, 1 hour after the glucose test. The patient's insulin levels are at 5 milliunits per liter. Control 40 plus or minus 11. What is this information likely to suggest about the underlying biochemical basis for the patient's symptoms? What would you predict the patient's fasted glucose levels to be given the current condition? Above normal, within range, or below normal? And then finally list 2 regulatory enzymes that are likely to be active in the individual's current condition. My answer. The lab results suggest that the child has low levels of available insulin. In a normal setting, the insulin availability of the 5-year-old child would rise significantly to compensate for the high level of glucose after the oral glucose test. However, there is only a minimal rise in insulin levels. With this information presented from the insulin levels from the glucose test, and the patient's symptoms of polydipsia and polyuria, I would suspect that this child has type 1 diabetes. Type 1 diabetes is an autoimmune disease where beta cells in the pancreas are attacked and destroyed, leading to a decrease in insulin production. Therefore, I would expect the child's blood sugar to be considerably elevated because of the lack of available insulin to use glucose for energy, or convert to glycogen for storage. The 2 regulatory enzymes active in this individual are glucose 6-phosphate and fructose 1,6-biphosphate. My sources are cited on the script portion that I attached to the Blackboard. So for my second case, case 4, the question reads, a previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports she has not given the baby anything to eat other than breast milk since birth. The baby only recently has been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, but are otherwise unremarkable. Epinephrine is administered, and there is no increase in blood sugar, but there is an increase in blood lactate. Physical exam reveals a liver edge 4 centimeters below the right costal margin, percussion of the right chest and abdomen conferring hepatomegaly. Blood glucose levels are increased after breastfeeding, but cannot maintain glucose levels within normal range during fasting. Based on this information, which of the following is most likely a diagnosis of the patient? Hereditary fructose intolerance, galactosemia, glycogen storage disease, glucose phosphate dehydrogenase deficiency. My answer. This 2-month-old female infant is presenting with glycogen storage disease. Glycogen storage disease is a metabolic disorder caused by a deficiency in glucose 6-phosphate, preventing the breakdown of glycogen to glucose, resulting in low blood sugar and lactic acidosis. Classic symptoms of glycogen storage disease are low blood sugar, enlarged liver from increased glycogen storage, slow growth, high levels of fat, lactate, and uric acid in the blood, muscle cramps, and anemia. The infant presents with 3 to 6 symptoms. She has low blood sugar, an enlarged liver upon percussion, and an increased lactate only after the administration of epinephrine, confirming our diagnosis of glycogen storage disease. Now, we can rule out galactosemia because there are no reports of nausea, vomiting, diarrhea, or fever, which are classic symptoms seen in galactosemia. The child does not present with poor feeding, irritability, jaundice, vomiting, seizure activity, or excessive sleepiness. Therefore, hereditary fructose intolerance can be ruled out. A glucose 6-phosphate dehydrogenase deficiency would result in hemolytic anemia. The baby would be jaundiced, have an enlarged spleen, dark urine, and increased heart rate. Our baby does not present with any of these, so G6PD deficiency can be ruled out. Like I mentioned, our answer for case number 4 is glycogen storage disease. That is the completion of my video. Again, my name is David Romaka. The date is November 20th, 2016.